Welcome everybody to Optometric Education Consultants National Webinar Series, Sunday morning edition. It's my great pleasure to introduce our speaker, Dr. Michael Shiglazian. He's an associate professor at Illinois College of Optometry and chief of staff at the Illinois Eye Institute. He's a graduate of the State University of New York College of Optometry and completed a residency in primary care, ocular disease, at the Pennsylvania College of Optometry. He oversees the glaucoma service of the Illinois Eye Institute. He provides patient care while instructing optometry residents and students there. He's a founding member and former president of the Optometric Glaucoma Society. His clinical practice is directed exclusively to patients with glaucoma while co-managing surgical care with 2 glaucoma specialists. His research interests include normal tension glaucoma, automated perimetry, and clinical use of OCT imaging. He has published a large number of articles and is passionate about teaching fellow clinicians in the care and management of patients with glaucoma. I have known Dr. Shiglazian for a number of years. We have been friends and colleagues for longer than either of us care to remember. I've worked with him on numerous panels and presentations and programs, and I can say he is probably one of the best and easiest people I ever have the opportunity to work with. I always listen to what he says. I always learn from him. He is really one of the true gentlemen in the profession, and it's a great pleasure to have him here. He's always welcome on my programs, and we're sure to bring him back both to webinars and live events. So with that, please give a nice virtual round of applause to Dr. Michael Shiglazian. Michael, take it away.
Joe, thank you so much for those really kind words. Really a pleasure to be here with you and everyone this morning. To pay the compliment back, your team at OEC is just really easy to work with on my end also. So always happy to do some work for you. And really, anytime we get together to talk about glaucoma, that's one of my passions and has been a passion of mine for many, many years. And so it's really an honor to be here and to share some updates. And, I really appreciate the survey that you did at the opening here to see where the audience is in terms of glaucoma. And I think this program is well suited to everyone in those different categories. The title, of course, is Roadmap for Making the Diagnosis of Glaucoma. Your question was a little more focused maybe on treating glaucoma, but of course we're all responsible for making a diagnosis of glaucoma, or at least identifying it and referring the patient to the appropriate location. And glaucoma is a rapidly changing landscape. There's just always new information. A lot of the basics and fundamentals are still there, of course, but there's new aspects, new twists, new pieces of information. And my goal here for the next 100 minutes is to share all of those with your esteemed audience. This will be mostly case-based, but a lot of information and background, current research, my 2 cents, if you will, my expert opinion on how to approach patients, and using all of the diagnostic tools that we have today to manage our glaucoma patients. It is certainly within the realm of really most all optometrists to take care of glaucoma patients. And I'll reiterate again, making the diagnosis is really the first and key step. So again, pleasure to be here on this Sunday morning. And I look forward to great interaction with our polling questions as we get through the slide deck here this morning. So these are my disclosures, but this is my presentation. I put it together, and it doesn't really have anything to do with work that I do with industry. So our topic and sections, we will focus on who is the glaucoma suspect. And I'm going to start off just by reviewing some of the key risk factors. Sometimes we get so overwhelmed by OCTs and visual fields and corneal hysteresis and perimetry, we sometimes forget some of the key basics. And I want to go back just to spend a few minutes at the beginning to talk about key risk factors, because that's something we can all identify via a good history and good question interrogation of our patients. We're going to spend a little bit of time on evaluating the glaucomatous disc. That's the old way, looking at photographs and knowing what you're seeing in the back of the eye. Don't worry, we will spend plenty of time on OCTs and visual fields. Those are still obviously critical in our workup and evaluation, but it's putting all of these data points together and arriving at a decision for your patient as to whether or not they have glaucoma. So that's basically how the lecture is set up. Questions that I often ask my students in the decision-making process for glaucoma is, are you going to treat this patient or not treat the patient? That's sort of the first question. I think you sometimes have to back up from that a little bit and figure out, why are you going to treat this patient, and tell me why you think this patient has glaucoma, and identify for me what the risk factors are. And those are things that should be documented in the chart. And if you can align your workflow and your assessment and clinical examination in the office to answer that question, you'll be way ahead of the game here. And then moving on, we'll talk about how to, well, not in this lecture, perhaps, maybe I'll come back and do a little bit more how to treat patients, how to modify treatments for patients who are progressing. That's really a whole nother aspect of glaucoma care. And again, I'll be happy to come back at some future point and talk more about that. But today we're taking a look at the roadmap. And the roadmap, is not really this simple for, it's simple like this for a few glaucoma patients, but more often than not, it's something more like this. And admittedly, unless you are heavily enmeshed in glaucoma care and management, there are a lot of data points, there are a lot of new pieces of information, there are a lot of new testing subtleties that come up. And so getting to a diagnosis or finding your way to a diagnosis can be a little bit complicated. I want to make it easy for you. I want to reiterate what the key fundamentals are. And I think if you apply these practices and aspects and clinical pearls to the patients in your practice, you will do just fine with identifying glaucoma and deciding whether or not you need to treat your patient. And then you can decide whether or not you're going to do the treatment or whether that's best off in the hands of someone else. So who is the glaucoma suspect? I think it starts really with a risk factor assessment. This is a very common medical practice in all disciplines of medicine to identify the things and underlying causes and etiologies of potential diseases in our patients. And rather than worrying about what the OCT shows right off the bat, or what the visual field is, or what X, Y, or Z is, I think we want to just take a quick look at three risk factors that we all know are associated with glaucoma. Let's just provide a couple minutes of update on them and see if there's anything that, just to, we can gel this together for everyone. Certainly one of the things that we know is critical in glaucoma is family history. We describe primary open-angle glaucoma as a multifactorial polygenetic disease. And it's been this multifactorial, multiple genetics, multiple markers for glaucoma disease that has been a little bit of a challenge in the genetic testing for glaucoma. But in a minute, I'll share with you how that is going to change pretty quickly for us in the very near future. One study that looked at family history in glaucoma was the Rotterdam Eye Study. It looked at the absolute risk of glaucoma at age 80 years of age and found it to be 10 times higher for individuals having relatives of glaucoma. So I'm trying to put some markers in there and some metrics, if you will, to put things in perspective. So certainly identifying family history we know and always have known is a key thing to do. But it doesn't account for everything. And there are some non-genetic factors that play a role in glaucoma overall. They may be more anatomic, they may be more environmental and other things that come up in our evaluation. Going back to the genetic side of things, here's just a very small sampling of the activity that's been going on in genetics research for glaucoma. And there are a number of companies that are working on what is very likely to be a very solid genetic test for glaucoma. And so we tried this over 10 years ago, and it wasn't a very good test, and it really didn't have much clinical application. But as you all know from the aspects of 23andMe and all the other genetic testing companies that are out there today, the sequencing of the DNA, human DNA chain has really advanced this field of information hugely. And the same has been going forth in glaucoma care. There's nothing clinically available yet, but I'm just highlighting for you that I very much expect in the next 2 to 3 years at least, at the most, that there will be a genetic test that is available for glaucoma, and it's going to be quite good. It won't be something that we use in isolation. It will still be what's called a polygenic risk score. So again, back to this risk factor assessment. And it will be one of the key pieces of information that you use in understanding your patient's risk for developing glaucoma in the future. And you'll be able to advise them relatively definitively based on the results and outcomes of this genetic testing. Moving on to another systemic, not another systemic, but a systemic disease that we regularly encounter in our patients and have had a lot of conflicting information in terms of its association with glaucoma over the years, is diabetes. And there was a number of older studies and data that suggested that diabetes was not a risk factor for glaucoma. And then other studies came out that said that it was a strong risk factor for glaucoma, and it's sort of been back and forth. And most recently, in the past couple of years, this publication that I listed up here did a meta-analysis, that is going back and looking at all the studies and trying to quantify as best as possible what the true risk for diabetes and glaucoma is. And I say, to my students and residents that, it is a risk factor. It's just not a very strong risk factor. It's not a tipping point for me for the vast majority of my patients. And so an increased risk of 1.35 times is not really that strong. So yes, it's important. What we really don't know is whether or not it's a significant risk factor for patients who are likely to get worse and progress. And we just don't have the data and information on that. So part of the pathophysiology of diabetes and diminished blood flow and things like that, there may be an impact not on developing the disease. Maybe it's already existing genetic markers and risks that cause the development of glaucoma. But if you have diabetes and glaucoma together, maybe your glaucoma gets worse more quickly or more aggressively, and you need to treat the patient more aggressively. Again, we don't know that definitively yet, but I thought that this slide sort of puts things into perspective for the never-ending question as to whether or not diabetes is a risk factor. If you think it's a simple yes or no, it's not that simple. And again, I think I would just put it as a very mild to modest risk factor overall. Another systemic condition that comes up is systemic hypertension. Again, here, there's no definitive link between elevated blood pressure and glaucoma. Most studies show that there is not an association there, and other studies show that high blood pressure may actually be protective. A little bit later on, we're going to review ocular perfusion pressure. This is something we don't always talk about, and we used to talk about it a lot. We don't talk about it so much anymore, primarily because we can't really have a great impact on it other than lowering the intraocular pressure. You can see there's a little formula there if you've forgotten what ocular perfusion pressure is. This is blood flow perfusion pressure, and sort of a surrogate for blood flow into the optic nerve. And the DBP is diastolic blood pressure. That's one way to do it, minus the intraocular pressure. And we get an increased risk of about OPP of under 50 to 55 milligrams of mercury. So this may be an issue, which is low blood pressure or over treatment of patients with high blood pressure where the blood pressure is too low. So at the end of the day, it's sort of a wash for me. I don't really consider blood pressure, even the treatment of blood pressure with topical oral beta blockers that can lower eye pressure a little bit. I rely back on the more significant risk factors that can really help me out, rather than trying to, find a turning point, a tipping point, a piece of information in diabetes or systemic hypertension. One new thing that you may have seen come up in the trade publications over the past couple of months is a study out of China that identified one of the statins, Crestor, with an increased risk of open-angle glaucoma. Again, as you read the text on the right side there, the odds ratio, or the OR, is only 1.11 increased risk. It's really not that high overall. This is really interesting to me. I mean, it was a very large study and a 10-year cohort study. It's interesting that it was just this one statin that was associated with increased risk. And it's also interesting to me because, boy, about 10 years ago or 8 years ago, they were saying to us that statins actually had a protective effect on glaucoma. So I think I put this in here to say, you know what, we don't know a lot of things about glaucoma still. And we're always looking for new pieces of information and, key pieces that could make it easier for us. I would reiterate that go back to the fundamentals, understand the fundamentals as best you can, drill down on those and use those as your guiding points more so than new pieces of information that, get spread around in the trade publications and seem like they're interesting, but, perhaps at the end of the day, I'm not going to treat a glaucoma suspect just because they're on Crestor and someone else is not, all other things considered. I will show you in this lecture what things really should be attended to.
Excuse me, Mike, you make such a valid point there. It wasn't that long ago that I think we all heard about the research of low cerebrospinal fluid pressure. Do you remember that, Mike?
Yeah. Yeah.
I mean, I'm not going to disagree. I'm not going to, dispute it, but how can we easily measure it? And even if we do, what can we actually do about it? And I can tell you, if you think you have a hard time getting patients to do visual fields, imagine lumbar puncture.
Yep. And we were sort of promised like an easy way to measure intracranial pressure, and that never came to be fruition. So I'll touch on OPP again, but really it's more of just a understanding of the disease process of glaucoma point rather than a clinical, I have to do this type of thing.
Or maybe we should actually try to get a couple lumbar punctures, and then those visual fields don't seem so bad anymore, do they?
That's right. That'll change people's minds. So again, and then, I haven't really addressed, but we will in the upcoming case presentations, the ocular risk factors related to glaucoma. You all know those very well. I won't belabor them here, but those, of course, are where we spend most of our time. But it is important to do this risk factor assessment. And with the upcoming genetic tests, I think you'll see a better role for this aspect of glaucoma diagnosis and understanding. So, here's some of the steps that I outline, in terms of when I get to this crossroads, what do I do with this patient? I go back and I do my homework. I go back and I identify what the positive risk factors are that I can really be solid on, and how do they really contribute to this patient's risk. I review all of my diagnostic data, and, it's just a little bit of a chore to, take all of these pieces of information and put them together. And I don't have a point system or a scoring system. I guess those help a little bit if you're very much a novice at this, but, you can line these up, and I'm going to show you a tool in the first case here that can help you do that and come up with an assessment overall of your patient's risk. And then, again, moving on is down here on the lower right-hand side, where we'll get to perhaps in a future presentation. So, Joe, here's our first polling question, and it has to deal with the data out of the OATS study. So if you want to pop up the polling question for everyone.
And it should be up for everybody to see. For patients in the OATS clinical trial, increased risk for developing glaucoma started at what point? Central corneal thickness 525 or less, 550 or less, 25 or higher, 7 CD or higher. I'm just kind of wondering if, Mike, if any of your students should be attending this, if these are going to be test questions coming up.
This is where they came from.
Mike, somebody that has a question. Family history of glaucoma refers to parents and sibs or grandparents as well?
Well, again, there's no easy metric there. The further the distance, the less likely the association with glaucoma. So closer siblings, parents, aunts and uncles, they tend to have a higher risk. I sort of keep it simple for me personally. Grandparents, I'm never really sure what's going on, but parents and siblings, very high risk factor. I watch the patient very closely, and I'm more likely to treat or at least monitor very, very closely.
Mike, you ever get those patients who have a strong family history of glaucoma, legitimate, and they've got a 15 pressure and a 0.2 CD ratio, and they're still out of their minds with worry?
Yes. And I do my best to reassure them to say that, glaucoma is that multifactorial thing. It's not passed directly from parents to children all the time. You should, probably for somebody who's 0.2 and a pressure of 15, just continue with regular yearly eye exams. I might do some baseline testing if, patient's really anxious, get a baseline field or an OCT. They have a risk for the disease, but to me, someone like that it's not imminent anytime in the near future.
Yeah, what I tell them to allay their fears, I start off by saying, in my opinion, the greatest songwriter of our time is Paul McCartney. Yet none of his kids have written a hit song. If anything is going to be carried over, you think it'd be that. So they seem to get it.
Yep.
All right, I'm going to end the poll and I'm going to share the results. That's what we have there.
So a pretty good split. So you want to hold off on the answer and have people pay attention until I get to the slide with the answer?
I think so.
Okay.
All right, very good.
So I put this question in there because this first section here and the first case is really going to deal with this risk calculator that came out of the ocular hypertension treatment clinical trial. And it can be a very, very useful tool for any eye care practitioner who is evaluating a patient with high eye pressure, because it's ocular hypertension, and at risk of developing glaucoma. And I'll get to that in upcoming slides. So the next couple slides here, I'll go through quickly because it's just sort of the background stuff. I don't want to belabor too much. This is, again, aspects of when to treat patients, and I'm redefining, making sure everyone understands that ocular hypertension is someone who does not have glaucoma, but a risk of developing glaucoma in the future. And all of their findings are basically just suspicious at this point, or really normal. Because if you see an OCT loss or a visual field defect, that defines them as having glaucoma with high eye pressure, that patient needs to be treated. But for those without any findings on their clinical examination, they often just need to be monitored, and only treatment or only early intervention and treatment for those at highest risk. And that's what the risk calculator will help us do. So the decision tree can be a little bit complicated sometimes, because on the flip side, we have patients with pressures of under 21 with, suspicion of disease. When we look at the optic nerve head, the visual field, the OCT, and, all these things can get a little bit mixed up for us. But I think if you take a systematic, methodical approach and, take an approach to dividing up your findings, on a grid like this. Again, some other people may use a point system or something. I just, ask my students, well, tell me why you think the patient has glaucoma. What definitive information do you have? Family history, elevated IOP. What are you not so sure about? Well, the optic nerve looks suspicious. Well, okay, lots of things look suspicious. Central corneal thickness, I'll get back to that in a little bit. This is actually low risk as a tip off for you. And then, our unreliable visual fields or a normal visual field. And then, what is saying that the patient does not have disease at this point. And I think if you separate that out, we do have these patients that have a mixture of findings. And for the most part, I would reiterate that most of these patients can be followed without, intervention with appropriate education and information when you do not have definitive findings, unless you have a calculation of a high risk. So again, here's a grouping of patients from the OATS study where we collected years of data, for 20 years now of data, but initially 5 and 6 years of data with glaucoma suspects with elevated eye pressure. There were no definitive changes on the optic nerve or visual fields. And ultimately what we identified were results that was on this grid here. That is, patients with a thin corneal thickness. And so the answer to the quiz question, polling question, was under 555 microns. This was the starting point for increased risk of glaucoma. And to be clear, this is developing glaucoma in the next 5 years. So again, try to make sure you understand the clinical study situation here. This is a patient with high eye pressure, over 21 or 22 millimeters, not higher than 32 millimeters, I think it was. And here's the risk of developing glaucoma stratified by corneal thickness and by IOP. And so when you drill down to this upper left-hand quadrant here with 36%, you can see a huge risk of developing glaucoma in the next 5 years versus those with a thick cornea. We call, by the OATS criteria, it's over 588 microns. I sometimes say close to 600 microns. The risk is only 6% of developing glaucoma in the next 5 years. So that's really the basics of the risk calculator. And one way to look at these outcomes is to think of thin corneas, thick corneas, and average thickness corneas, where we don't really have a change in the risk assessment. Those with thin corneas, and the closer to 500 microns you get, the higher the risk. Most of these patients probably should be treated after the appropriate diagnostic information is collected. Many of these patients with thick corneas perhaps don't need to be treated. Now, you can still have glaucoma patients in this group, so it's not 100% protective, of course, it's just a lower risk. And so if you develop this philosophy of the risk assessment, you'll try to categorize your patients into low risk and high risk, and you'll treat them accordingly. So under 555 microns was the tipping point, starting point for increased risk in the OATS study. And then the slide here just describes, how do you manage patients who seem to be a glaucoma suspect? Their pressure's not over 21, it's 21 and under. Whether or not they truly have this thing that we sometimes call normal tension glaucoma, or whether or not their pressure is varying between 18 and 24, you just haven't been able to catch them at the peak IOP of 23 or 24 that may be happening nocturnally while they're sleeping. These patients in the office have pressures under 21. And again, they don't have anything definitive on their OCT and visual field. Many of these patients can be followed every 3 to 6 months, repeating your diagnostic testing accordingly, and you'll be fine. Another guide point that I sometimes talk about is, you may want to initiate therapy for patients with pressures under 21, so they're not ocular hypertensive again, and they have 3 or more risk factors, sort of that I haven't put everything into this bottom group here, but if you feel that they are truly high risk, like if they had multiple family members in close proximity with glaucoma, and things were suspicious enough, it wasn't a 0.2 CD and a 15 IOP like Joe gave an example of, but more of a, 0.6 CD and some funny things on the visual field, those are patients who you may decide to initiate therapy on. But otherwise, it's for those patients with definitive changes on their optic nerve head that you see clinically, or you have a reliable OCT without any artifact and no red disease, just true glaucomatous nerve fiber layer loss, and or visual field loss. Patients with pressures over 30, these are the patients who we put in the category of certainly needing treatment. It's always important to consider the age of the patient, their comorbidities, their life expectancy. Younger patients are going to live for a much longer time period, and that risk from the OATS risk calculator only carries for 5 years and not their lifetime. So we may need to recalculate every few years. We may need to add in different data to the OATS risk calculator, as I show you that in the next case, and modify it and keep it updated. And then again, patients' understanding of the disease, the risks and benefits of treatment. This is all the other stuff that goes into the management of a glaucoma suspect or somebody with early disease. And it really will develop a practice philosophy and treatment philosophy for yourself overall. So I hope you appreciate that, glaucoma is a puzzle. We're here to help you put all these different pieces together. My cases are coming up here to help you deal with the discrete pieces of information and data so that you can see how this all works together. Now you have some general understanding of the fundamentals and the identification of who's a glaucoma suspect and the risk assessment part.
Hey, Mike, before you go on to the cases, there are a couple questions that came in. I want to share them with you now.
Sure.
One goes back to corneal thickness, and does it matter if the cornea was thinned due to LASIK?
Yes. So you cannot use the pachymetry findings from any patient who's had LASIK in the past. The pachymetry findings we're talking about from the OATS study were on patients that did not have any refractive surgery. So unfortunately for a patient who's had LASIK, you're more likely to measure lower eye pressure. To recalculate it is virtually impossible. You might consider using the ocular response analyzer or other devices to try and get a true measure of pressure, but you cannot use the pachymetry findings from a LASIK patient.
And there's another question, Mike. You may be coming up on this, and if you are, you can just skip over this question, but can you expound upon red disease? That was in our chat.
Yes. Sorry, I mentioned that briefly. I will definitely show that on the OCT reports that are coming up.
All right, very good. So
basically, it's not true disease.
We'll table that discussion to the examples. Very good.
Thank you. Okay, ready for the case?
Yep.
Okay, so again, I'm just giving you the highlights here because if I get into too much detail, we'll do one or two cases, the whole thing, and I'm going to try and cover a lot of ground here. This is a 56-year-old with a positive family history of glaucoma, is being treated for systemic hypertension. Going back a ways, we've got some early eye pressure readings. These are sort of cut out of my electronic medical record here. And you can see the readings for the right and left eye there, 18 and 20, 17 and 20. You can also see the pachymetry findings right at 556, right at 561. So again, what I do with this is the patient really isn't ocular hypertensive at this point. You can't really apply the guideline that I just gave you because they're not really at 21 or over, or even 22 millimeters or over. So it's good to know the pachymetry, but you can't quite use all of the risk calculator data that I'm going to show you in a little bit. So just keep that in mind. What I say here is that this is not a very thin cornea. It's an average thickness cornea for our glaucoma patients. And, maybe we'll come back to it. Maybe it'll be more important to us later on. We take a look in the back of the eye, of course, and we have good, wide field photos here. We can even drill down with these camera systems now and try and look specifically at what's going on in the optic disc, the neuroretinal rim and the cup area. And basically, we don't see anything significant here in terms of a relationship to glaucoma. We're going to talk more about optic nerve evaluation in an upcoming case. This is the OCT from the Cirrus device here, retinal nerve fiber layer and optic disc on the left-hand side in the report there. We can just quickly look at the thickness map, the deviation map for the right eye, thickness map, deviation map. Deviation maps are very helpful if your OCT has them because they tell you where the abnormality is. And as you know, we're looking for wedge-shaped defects in the superior temporal and inferior temporal region in general. We're not looking for splotchy stuff all around, and we're trying to make sure that a patient is we're just identifying glaucomatous change here and not other retinopathies or optic neuropathies that may be present. And then we may look at the average RNFL thickness. We may use the quadrant or clock hour plots down here to help guide us there. And then we also use the ganglion cell analysis. So a separate scan in the macular region. Virtually all OCTs do this now. And if you're using an OCT, make sure you're getting a macular scan to identify the ganglion cells. So different from the retinal ganglion cell axons that we measure around the optic disc. And here on the deviation map for the left eye, we have a small area here. It's not perhaps significant enough to be true evidence of glaucoma disease. And we have to recognize that in the macular region, we get lots of, again, what we call artifact. This might be an example of that red disease where you see red on the report, but it's not due to true disease or true glaucoma disease. It may be a poor quality scan. It may be some other retinal abnormality. So that's one example, and we'll show more examples of that. So that was the early OCT of this patient, not showing anything significant for glaucoma. They were a suspect again because of family history, and maybe a little bit of, large cupping on the CD, but no definitive glaucomatous changes. OCT was run, it was normal. I'm not sure a visual field was done at that time. A lot of times when the OCT is completely normal and the risk is low, I might not do a visual field because it's probably not going to show me anything, and I might hold it off for those patients who really need to sit for a visual field. But time goes on, and so 2 years later, this patient returns, and the pressures are now 23 and 26. So now we are in the ocular hypertensive category, and we can start to apply more definitive pieces of information. We have to do a careful slit lamp exam and look for other features and findings that may be related to secondary mechanisms. We want to do gonioscopy and look at the angle structure in each eye. We want to make sure that this is an open angle case and not some form of narrow angles or angle closure. Certainly at this point in time, we're going to do visual fields. And like many of our patients, the first fields, this actually just looks, I'll say, messy to me. It has a lot of edge artifact on the black squares. I generally look more at the pattern deviation plot down here, pattern deviation plot for the left eye. This is all edge points. There's a generalized depression. It's really not indicative of any true disease there. The patient probably needs to have that repeated at some point in time in the near future. We take another set of photos. Here's a little bit more clear delineation of what's going on in the optic nerve. I see some asymmetry in the CD ratio. It looks larger on the left, but it's a pretty well perfused neuroretinal rim, a very intact neuroretinal rim, meaning I don't see a notch, at least on the right eye. The left eye is a little bit thin, maybe. I just go by the slope and the change there, but I can't say definitively that there are any glaucomatous changes there. And yet when we repeat the visual field, the right eye gets a little cleaner. And there's still a couple of edge points here, but the left eye has all of this stuff here now superiorly that looks like a more classical glaucomatous visual field change. Note here at this visit, the eye pressures were now 22 and 28. So I have a second reading of, high pressures. And again, I didn't treat just because the pressures were 26. I'm collecting data and information and going step by step, seeing the patient every couple of months at this point, or perhaps every month as I am accumulating this data and information. I'm going to repeat the OCT. And now, if you remember back, still nothing on the retinal nerve fiber layer, but maybe much more change on the ganglion cell plot down here for the left eye. And that's a pretty significant increase. So that may be, indicative to me. Now, we don't always see early change in glaucoma on the ganglion cell. Some people think that that's where all the early change happens. That's not necessarily the case. In fact, what I like to see is really change on the ganglion cell and the RNFL. So you should look over here, and I'll lay this out for you on another slide, that these two things should sort of be related together to really be sure of what you're seeing. We repeat the visual field a third time. Patient loves us for this. And now that significant defect that we saw superiorly in the left eye is pretty much banished. Again, improved test taking, learning, better instructions and directions. This is what tells this is what affects the subjectiveness and variability of visual fields. So does this patient really have glaucoma or not? And I think, what I try to do in these cases is go back and put all the information together. Perhaps you've heard of structure function correlation. And so in this layout here, I am trying to correlate the structural damage from the OCT, both the ganglion cell. I don't see anything on the RNFL. That's a little bit suspicious to me, but it certainly can happen. And then because this is inferior loss here on the ganglion cell, I flip this around to the pattern deviation plot. And if this is a real field defect up here, this does correlate with my patient. I go back and look at the eye pressure readings. And as you'll see here, the patient has had even increased eye pressure readings over the next couple visits. So we got up as high as 32 and 34. And clearly this patient is trending in the wrong direction and is going to need treatment. But I think there's still something else that we can do for this patient, rather than just tossing a coin, figuring out like, is this really early glaucoma? Do I just treat based on the IOP? Or if I didn't have these pressure readings of 34 and 32, I just had the 25 and think there was another one at 26 in there, or 28. You know, what do I do at that point? And so here's where I want to introduce something that can help you get help you be less confused and less unclear about these patients with early stage glaucoma. And again, it goes back to the OATS study and the ocular hypertension risk calculator. And the calculator looks like this. So you go online. I think this is a helpful tool for a lot of people who are not doing a lot of glaucoma. And from the poll, that's a good percentage of you. If you find someone with high eye pressures, you enter their age, their untreated eye pressure, preferably to get 2 or 3 readings, enter it into this grid here on the web page. So you go here and this grid pops up and you enter it in. You have to have a pachymeter, of course. I take 2 or 3 readings on one day. You don't need to repeat them on different days. It doesn't change. And per the question earlier, you can't do this on somebody who's had LASIK. Or really any other corneal surgery. You know, you can't have anything. You need a quote unquote virgin cornea, if you will. You want to give a vertical CD ratio by your clinical estimation of the photograph or your condensing lens view of the CD ratio. And then you need a value from your Humphrey field analyzer. And if you don't remember what the PSD is, the pattern standard deviation value, it's this value. Actually, I have it blocked up right in there. It's that value in green right there. You do need a white on white perimeter. And it has to be of the Humphrey or octopus variety. And all those data points go in, and what you get out is a risk of your patient developing glaucoma in the next 5 years. Now, again, what I did on this case here, as you see, is I put in these high pressures of 32 and 34. Now, you might say, well, that patient definitely has glaucoma if you have a pressure reading of 34. You know, I'm not going to quibble or argue with you there, but at that point in time, I think there wasn't really anything definitive on the visual field in OCT. Now, again, we're getting into some nuances here with, well, there was some ganglion cell change and there might have been an edge artifact, but I'm using this mixed case as an example for how this risk calculator can give you a predictor of what's going to happen in the next 5 years. And so the question is what does this 16.3% mean? And that's going to take us to the next polling question. All right. The question is related to what risk is significant. So Joe, if you want to pop that up.
Here we are.
So
go ahead.
Go ahead.
No, you please.
So you've done the risk calculator. You've gotten a value. Now you scratch your head and you want to know, well, I don't know what the high risk is. Is it over 5% risk of developing glaucoma in the next 5 years? Is it over 10%? Is it over 15? Or is it over 20? And at what point does expert panel consensus decide that your patient should probably be treated for ocular hypertension without any definitive OCT or visual field changes? So admittedly, a little bit different from the case that I've shown you here. But as a metric, you can use this free tool. It's free, and that's why no one ever talks about it, because they're not trying to sell it to you. And it will help guide you and may help guide your patient and help your patient understand why they do need to be treated or why they don't need to be treated. So we'll take a look at the results there, and I'll give you the answer on the next slide.
Now, Mike, while we're still waiting for a few more people to weigh in, we're doing pretty well. There was a question that came in, or two. One, is tonal pen measurement acceptable for IOP? And maybe I'll even add to that myself about eye care, alternate forms of tonometry. What are your thoughts?
I think alternate forms of tonometry definitely have a role and can be very accurate in clinical patient care, and even for glaucoma patients. I prefer to use tonopen in eye care when I can't use a Goldmann tonometer. So if you have patients where you can't get them in for a Goldmann, and this is a glaucoma patient, then certainly alternative forms are better than nothing. You have to know the limitations of the tonopen in the eye care. And again, in general, they're pretty good devices overall. They are sometimes a little bit more variable. And I think that they don't work well at the higher pressure ranges. But if the question is, tonopen eye care in general practice, absolutely. Tonopen and eye care in a glaucoma practice, not preferred, but as an okay substitute.
I agree with Mike. I mean, if it's FDA approved for the measurement of intraocular pressure, it's well maintained and it's being used properly with proper training, I think this should be all very
Yep.
reasonable. Now, in my hands personally, a tonal pen is about as accurate as a psychic prediction. Now, can you touch on corneal transplant patients on long-term steroids being treated for high pressure with increase in corneal thickness?
So a patient like that with a corneal thickness of 600, 625, steroids and everything else, a lot of that treatment is somewhat, maybe the word is empirical or just by your gut, based on looking at the optic nerve. You're not going to know what the real eye pressure is. You may have an indication that the pressure is increased over the past several months. But it's really, those are very tricky patients. There are no clear guidelines. It's an amalgamation of all the clinical data and taking your best guess. And I'm sometimes just figuring that the patient is better off to be treated moderately, perhaps not aggressively, to try and lower the pressure. But, corneal edema, thick corneas, steroids, those are all confounding factors here.
And just to wrap up a couple things here, what are your thoughts on non-contact tonometry and dynamic contour tonometry?
I don't do any dynamic contour anymore. What is that? The Pascal device?
Yes.
I'm not using that anymore. Yeah. The NCT, Joe, I would echo what you said, which is, has it been properly maintained? Has it been calibrated? If you're using it appropriately and you recognize what the foibles of it are, then it's perfectly fine. New NCT devices are really excellent. Again, they're not the preferred device in a glaucoma patient population, but they are, they're okay.
Okay, well, we have the results. The majority have said over 15%.
Perfect. And I'll say great job, everybody, because that is what the experts felt also. So after the OATS study came out and the risk calculator came out, and the risk calculator was improved and then validated in a couple of studies. So it's not just a flash in the pan type of thing. It's been around for a long time. Not many people really talk about it. I like to recommend it because I sometimes feel there's a good balance between talking about $80,000 OCT devices that people can't afford, or $30,000 perimeters that they don't have. How do you handle patients with ocular hypertension when you're not sure how to make a decision for them? So again, this expert panel recommended that most patients over 15% risk should be treated. In the middle, you still have to use your thinking cap, and you still get, you're still paid to be a doctor. 5% or less, they probably don't need to be treated. Of course, the risk calculator does not include all risk factors for glaucoma. So if I go back a couple of slides here, you see it does not include family history. It doesn't include things like advanced hemorrhage. And again, it's not having a glaucomatous field defect. It's just the pattern standard deviation value in very early field changes can start to increase. And that's why that's there. So not a perfect tool, but I think a good tool.
And Mike, remember when the first iteration of calculators came out, diabetes was in there.
Yes, right. So, and I didn't mention that on my diabetes slide earlier, because of the way questions were asked and patients were enrolled in the OATS study. At first, it turned out that diabetes was protective in the OATS study. And because it was one of the key points, they had to include it. And then they got smart and they found okay, this is not right. Diabetes is definitely not protective. It may not be a strong risk factor, but then they took it out. And this slide here just talks about the most recent update, 20 years now of OATS data, which is basically saying two things. One is that most patients with ocular hypertension still do not develop glaucoma. But, 1/4 of them can develop field loss. So 1/4 is a lot. So these patients, they're all in our practices with the aging population. They need to be followed. If you have at least a perimeter, they should have some sort of baseline OCT at some point and have that performed periodically. They can be followed and managed. 3/4 of them in general will not develop glaucoma, but those with thin corneas, those with a family history, those who develop a disc hemorrhage, those with a larger vertical CD ratio, and maybe this ocular perfusion pressure thing here, or maybe not, those are the patients who need to be treated, and we need to intervene and treat them. So our next case is dealing with pressure in the normal range. So let's switch from ocular hypertension to many of the patients that we see who have pressure that is in a quote unquote normal range. This is a 44-year-old Black male patient. Last exam at a vision center a month earlier, was identified as having large cupping. The clinical exam shows 20/20 vision. All the entrance tests were normal. Slit lamp exam was unremarkable. IOP, I'm using Goldman here for whatever it's worth, of 16 and 15 at 9 o'clock in the morning. There is a family history on the mother's side. She is on topical medications, but not had surgery or anything. That was about all the history that we could get. We do gonioscopy on all of our glaucoma suspects, so you do need to practice that and try and watch the videos online and whatnot, so you can get a little bit better and more comfortable with gonioscopy. Here I'm taking just the IOP reading and perimetry reading out of my medical health record here. So the IOP is 16 and the cornea is 523 and 533. So again, thin on our scale for ocular hypertensives, but with a patient with pressure in the normal range, we can't apply the OATS data in exactly the same way. So we're not sure how much of an increased risk that this might be for the patient. Note, we do not recalculate the IOP based on the corneal thickness. We've been saying that for a long time. That was misinformation from 15, 20 years ago. This is what the optic discs look like. And I think you can appreciate there that this is a suspicious looking large cupping patient. Perhaps the disc size is a little bit large. We'll have to get our measurement from our OCT. We have a very thin neuroretinal rim. We have a very deep cup. We maybe have a little bit of retinal nerve fiber layer changes. If you look carefully up here, we're looking for striations and dropout on the retinal nerve fiber layer. And this is why your fundus cameras can be so helpful. I mean, even if you don't have an OCT, a good new fundus camera system and wide field images can often show nerve fiber layer changes. Again, here, these discs are just, and these cups are just really large and very suspicious. Here is a OCT example from another device. This is the Topcon Maestro device. And this is one of their newer reports that is organized by Don Hood. And here what he's done is he's identified a more magnified view of the B scan image of the retinal nerve fiber layer circle scan around the optic disc. So we take that circle scan that we always do around the optic disc, lay it out, and we're looking for areas of thinning. We're looking for the thinning here in the temporal region, which Don Hood has put in the middle range here, unlike the Zeiss device where the temporal side is, we use the T-SNIT curve. This is end-stint, starting with the nasal on the outside, and that's better for us because the key region is in the middle here. We have a thickness map, and here's some of those wedge blue defects that I thought maybe I was seeing on the color photograph. You might use the quadrant or clock hour plots, but I also use the deviation map, or here it's called a probability map. Deviation map, probability map, meaning the same thing. And if your device has this, this helps highlight for you in red what's abnormal. And the other thing that on this report that has been done is that it's been flipped upside down to present it in a field view. The advantage here is that you can then match up these red arcuate defects superiorly and inferiorly to the visual field, because the black points here in this area show you where the grid pattern is from the 24-2. So the goal here for all of this, why am I showing you all of this? This is because it helps to integrate the structure function, the structural OCT, the functional visual field, and it helps get our minds around the assimilation of all this data. That can admittedly be quite challenging. When you're looking at all this data, it's in different parts of your electronic health record, it's on different devices in different rooms in your office. I'm trying to show you that you need to bring all the data together in order to make the most accurate assessment. And then down in the bottom right is the ganglion cell analysis in the macular region. And again, we have two regions, superiorly and inferiorly, on the probability map that seem to be quite abnormal. And so this is fitting the bill for a characteristic glaucomatous change. And the left eye shows a very similar thing. Now, to help you understand this structure function thing that I'm talking about, let's say that we take this field view from the OCT report and match it up with the patient's. I haven't shown you the visual field yet, but here's the patient's pattern deviation plot from the visual field. And again, the idea is that you would transpose this right on top of the OCT. And these little black circles here would match up with the little black points here. Now, all of the data is not integrated because Topcon's not playing with Zeiss, who's not playing with Octopus, it's not playing with, all the different companies are keeping their data a little bit discrete and separated. And that does us and our patients a disservice. But here you're seeing that there's good alignment and structure function correlation on both the RNFL map up top and the OC and the ganglion cell down below. When you have this type of structure function correlation, you can be more assured that your patient likely has glaucoma disease and that it's not artifact or this other thing that we've mentioned, red disease, which is not true glaucoma disease. So that's the structure function for the Topcon OCT in the visual field. Here's what the visual field reports look like overall. I'm using a CETA-FAST strategy on the Humphrey field analyzer, doing a 24-2. And again, this is a first time field, so there's probably just a lot of noise here, and there's still needs to be some we need to repeat this and confirm these changes. That was the end of visit 1. Even with these changes here, I wasn't ready to treat the patient. Pressures were quite low, as you recall, and I need more information. Even though I am, pretty sure this patient has disease, I don't need to jump in on the first visit. Bring the patient back. I'm lucky in my environment. I've got multiple OCTs just to confuse my students and residents and sometimes my patients. But if you're more familiar with the Zeiss OCT, here is the color map, thickness map, and the deviation map showing very similar changes to what we saw with the Topcon device. What I am looking at more so these days is a new presentation called the PanoMap. And this stitches together the retinal nerve fiber layer and optic disc with the ganglion cell. So you can see how these two are connected together. And this just makes more anatomical, pathophysiological sense to me. We should be looking at a larger region of the back of the eye all at once. Unfortunately, the Zeiss instrument is only geared to scanning the optic nerve separately from the macula and doesn't really always do a great job of stitching them together. But when they correlate together like this, that's more likely to be glaucoma. As you may know, when you see central ganglion cell changes here, you need to consider doing central visual field testing with the 10-2 visual field or one of the other new patterns, which is the 24-2C from Humphrey. And here again, we see what I showed you earlier on the pattern deviation plot. There's abnormality here. You don't see it on the grayscale, but there does seem to be some abnormality here on the pattern deviation plot for this patient. So that was the end of visit 2. By the time we got to visit 3, we have now 3 pressure readings at 17. And I felt at this point, with the family history, with the OCT findings, with the visual field, that it was appropriate to start treating and intervening. Now, some people will argue that for pressures in this normal range, you have more time, you can wait to observe. Some people might want to wait for progression, but I think this is a high-risk patient and that intervention is warranted. And so I chose a prostaglandin product, one of the newer ones, latanoprostene bunode, which is the Vyzulta product. I dosed it once a day in the morning for this patient. I sometimes ask my patients when they're going to be best to remember taking the drops. And I brought the patient back in 2 or 3 weeks to recheck the eye pressure. And, it's going to be tough to treat this patient. We're searching for a 30% drop in eye pressure. I only got 3 points. That's not quite 30%. This is going to be a tough patient to treat and to follow and to have a meaningful impact. But at this point in time, I've started treatment. I found something that's safe, effective, well tolerated. There's no side effects with this Vyzulta product. At this point, I'm just going to monitor the patient closely. And at any sign of progression or change over the next year or two is when I will ramp up therapy significantly.
Hey, Mike, can you go back one slide, please?
Yes.
I think this really underscores the importance of getting several pre and post-treatment IOPs to see what's really going on, because if you look at from 17 down to 14, there's a 3-point drop. But if we looked at he had a pressure of 15 down to pre-treatment and 14, one may say it's not working.
Yep.
I think we have to avoid that visceral knee-jerk reaction after one pressure saying, "Oh, this doesn't work." Well,
yep.
We don't really know that. We can't just abandon it.
Correct. And at some point in these patients, Joe, I decide to dive in with the treatment, and after 2 or 3 visits on treatment, then I decide it's not really working. And what I do then is, as I'm sure you do, is do a reverse trial. Stop the medication. Even though I know the patient has glaucoma, it's okay to stop a medication for a short period of time and get another baseline. And make sure that you're trying to do the best you can. A patient like this, I may consider using the home tonometer. Trying to do my best to get an early morning IOP and a late afternoon IOP, and trying to find an IOP spike if it's there. It's going to be a challenging patient, and you have to go step by step.
I think one thing, if we go to the evidence and what we know about glaucoma in this true normal tensive range, I think the biggest studies have shown a lot of these patients actually don't get worse over time, even without treatment or very quickly at all. So
yep.
This is one of those things that you can easily, hey, sit and watch and see what happens.
Absolutely. That's exactly what I said. Like, okay, I'm treating him. Again, that's because of the appearance of the nerve, the OCT, and everything else. I think it might not be a smart idea not to treat this patient. Again, the family history also is a big tipping point there. But I'm not going to treat him too aggressively until I see some further change. And once I know he's progressing, then the wheels are off the bus, and we got to get really aggressive. But he may stay stable at this point in time, stable at this level for any number of years. And we saw that in several of the normal tension glaucoma treatment trials.
Yeah, certainly not a person to shuffle off for a trabeculectomy right away.
No, correct. You've got time here. And I think that's, again, that while we're talking about, glaucoma overall, that's the biggest thing for people to keep in mind, that you do have time, and you have the tools. If you know the risk factor assessment and you're collecting the information, take some time and figure it out. Yeah, ask a question at a conference and a meeting, and reach out to your colleagues.
Yeah, I've always said and reminded people that open angle glaucoma is a disease of months and years, not days and weeks.
Right. So it's definitely a marathon.
Mike, there are a couple of questions here in the chat room. Mean deviation versus pattern standard deviation progression. How much relevance in progression or risk factor? And that's how it was written.
So for mostly, I think, Joe, we're not using PSD value very much anymore. It was something we used to talk about a lot, 15 years ago and more with visual fields, but mostly the tracking of progression is with mean deviation values and or the VFI, the visual field index that Zeiss gives us on their GPA analysis. Which is basically related to the mean deviation. So we use that for progression. Using PSD value change over time, it can be done, but there are a lot of hurdles in there and potential red flags or mistakes.
And Mike, here's another question, which you may not have an answer to. I don't think I do. Is there an OCT company that's working on integrating the useful data that clinicians need?
Is there an OC? Yes and no, I guess. Not significantly enough to my knowledge with the OCT companies to really make our lives a whole lot easier. I think where the OCT companies are starting to look is on the artificial intelligence. But you know, and there'll be some algorithms more so on disc photographs first, and optic disc photographs, and then maybe OCTs. But the way it should be done is to take all of the data and put it together. And the companies are just not really all working together that way, unfortunately.
No, we have to put the data together in our heads.
Yes, that's why we're here this morning, right?
Yep. All right, I think that's it. That's it, Mike.
Okay, we got a polling question next, Joe.
All right, I'll get that up for you.
And actually, if people were listening earlier, I tipped the hat here a little bit. This is just a quick thing on ocular perfusion pressure. And I'm just going to touch on it for a couple of slides here and try and move on quickly here because we're running out of time. So when is ocular perfusion pressure significant? When measured at less than 50, when measured at greater than 50, never significant. It has been disproven. Never heard of it.
And Mike, if you run out of time, want to get through half your presentation, we'll bring you back for the other half.
Yeah, I got a lot of slides in here, Joe. I love doing this stuff, and I always think I'm going to do more than I get to.
Hey, you know, the Rolling Stones don't play every song they know when they go on tour.
That's right. My set list is one thing, and what I actually deliver is something else.
Mm-hmm. You know, actually, Mike, I used to do this neuro-op lecture, and there's case-based, and there's so many cases, and I never got really ever through it.
Yeah.
And then one day I just flipped it. It started going, I went backwards.
Yeah.
And it was actually a better lecture.
Yeah.
I just need a few more people to participate. We're
Good.
getting there. In fact, I'm going to, I think, end in just a second. All right, let's end it so you can get through your materials.
Yeah.
Looks like when measured less than 50, more than 50. So your answer is when it's less than, the majority is when it's less than 50.
That is correct. And so just again, a quick set, we don't, again, Joe, I think you pointed out ocular perfusion pressure and, you know, intracranial pressure and all this stuff. It's sort of a side point today for understanding glaucoma disease. It's related to nocturnal time period when patients are in the recumbent position and sleeping. This is when there's increased episcleral venous pressure. This increases the eye pressure nocturnally. And then simultaneously in the nocturnal time period is when your blood pressure drops down by about 15 or 20% normally. And so it's this lowering of blood pressure and elevation of eye pressure that lowers your perfusion pressure. And Joe, as you know, there are a number of studies of this, boy, you know, 15 years ago or so. And it's still sort of an interesting point, but to your point earlier, there's really not anything we can do other than lowering the eye pressure. And yet sometimes I find that when I have students, residents, practitioners not really understanding why we do certain things with patients with pressure in the normal range, this is one of those things that you can help, that can help explain it. And it may be something that needs to be investigated in terms of their overall general health and their systemic health and their blood pressure findings if they have very low blood pressure or low diastolic blood pressure, because that's when this gets to be significant. So you can see the example there. You know, I've sort of made up a diastolic blood pressure of a very low reading of about 65, which in some elderly patients is not, you know, that uncommon. And an eye pressure of 20 gives you a ocular perfusion pressure of 45. Here's sort of the tipping point and increased risk over here. And it's just, you know, something else to consider overall as we think about this.
You know, like another question came in. I think it's a great topic of a conversation, if you don't mind. They
Sure.
ask, is there an elevated IOP that you would treat to prevent retinal vein occlusion in the absence of glaucoma signs? I've got my answers for that, but I'm going to let you run with it first, please.
You know, Joe, I'm interested to hear your answer because I am not clear as to what the real risk is between elevated eye pressure and retinal vein occlusion. There is certainly some association, and association with patients with existing glaucoma developing retinal vein occlusions, but as a protective thing, I've searched the literature. I'm not clear that there's a definitive answer there.
Now, I mean, the best answer I saw actually came from the OATS study. They actually looked at the eyes that got vein occlusions treated versus untreated, and there was a difference, but the difference was like a 1.4% versus a 0.7%. There are only 26 over 11 years in 1,600 patients. Here's my response. Yes, I see vein occlusions in glaucoma patients frequently because of comorbidity.
Right.
Those are all glaucoma patients who are on medication being treated with a good IOP. Conversely, I commonly see patients 50, 60, 70 millimeter IOPs. I have never seen a vein occlusion in any of those eyes.
Exactly right.
I dropped the mic. Boom.
Yep. I think, you know, that comes like from Hayray's information from like the 1970s or early 80s or something, where he seemed to suggest that lowering eye pressure was somewhat protective about retinal vein occlusions. But I don't really believe it. And I would say the answer is treat the elevated IOP based on, you know, classical OATS risk factors and whatnot, and not so much on the vein occlusion thing.
I agree 100%, Mike. And for those of you that don't know Sohan Hayray, he is the king of "I'm always right and you're all stupid."
That's right. That's right. Okay. Next section here is just to review looking at the optic disc, and then I want to sort of move on to other cases and the OCT part. But you know, this is just, you know, a reminder that you still have to do this. I know it's COVID. I know you don't want to get close to the patient. You know, I highly recommend camera systems and fundus imaging systems to help you out with this, but you got to know how to look at the optic nerve. And maybe it's just a little bit of a concern of mine from the way we're training our students and the way practitioners are moving. It's like, you know, they're not looking in the back of the eye enough. And there's still all of these classical things that go on to identifying a glaucomatous optic disc. So, you know, here are a couple of examples of, you know, a normal nerve that looks very suspicious. Maybe it's a little bit washed out there on the photograph. You know, the cupping is large. Everyone knows we don't go just by the CD ratio. You may relate it to the retinal, to the visual field. You may be able to see the retinal nerve fiber layer on your color photograph, particularly with patients with darkly pigmented fundus or fundi, where the white striations of the reflections of the photograph show up there. You may see the slit-like defects of retinal nerve fiber layer loss.
You know, Mike,
this is what I'm talking.
You know, that last example that we all see all the time. I always advise these patients, if you insist on having a suspicious nerve, you better be a good field taker. Otherwise, don't complain if you get treated for a disease you don't have.
Yeah. You do have to get these patients through the test, and the OCT can help out. Although the OCT, particularly when they're large discs, the OCT can throw that red disease and artifact at you. And I'll talk about that if I get to it coming up. Here's what we're talking about for retinal nerve fiber layer loss. Again, everyone's seen this 100 times. But again, I'm pointing out, you can see it on a color photograph, admittedly a very advanced stage of retinal nerve fiber layer loss, but you don't want to miss it then for sure. And the OCT will help you identify it much earlier on. And then, you know, relate the visual field and do your structure function correlation. Or, you know, look at your OCT, and the OCT will tell you to look where to look in the back of the eye. So it's just, you know, this section is just to reiterate that looking in the back of the eye, even in patients with small cups. Now, patients with small discs and thus a small cup size, they can be some of the more challenging patients to identify glaucomatous change in, because all the retinal ganglion cell axons are crowded together. There's the same 1 million plus or minus ganglion cell axons, and the nerve fiber layer dropout or an early notch is just more difficult to see. So you may need your OCT to help you or a good fundus imaging camera. And here's a visual field for that patient. And you can see how, field defects don't go just by the grayscale. Look at the total and pattern deviation plot. Look at how it respects the horizontal midline, and look how it has this arcuate shape going and leading back to the optic disc and blind spot. Here's another patient with an inferior notch. Right in here, look for the deflection of the vessels. That's why photographs are so great to use for this. But don't take a photograph and not look at it, because that'll get you in trouble down the road if your patient actually has disease and you missed it. Notching up here, just by thinning the rim. Of course, doing this with a stereo view is, gives you much better detail and an easier way to identify these things. And that's basically on clinical examination. I actually am not doing stereo photographs regularly anymore. Not with an OCT. I find I can get by with an OCT image and a flat 2D color photograph of the optic disc. But if you can get stereo and use it, it's certainly better. Larger advanced notch, and again, it's all in here. Primarily, I'm not using color. I'm using deflection of the vessels and where the rim tissue has been lost. Much more advanced stage, sort of the classical bayoneting of a disc, of a retinal venule at the disc margin, and a notch occupying a couple of clock hours, and the visual field that went along with that. And going back to our wide field photographs with one of the currently available camera systems, you can see it right there. These are the easy ones. The subtle ones, take your time with. Don't worry about it until things really start to make sense with all of your clinical data mostly pointing in the same direction. So here's a patient, 54-year-old African-American. IOP is in the range of 16 to 20, 16 to 19 in the left eye, very thin corneas, and corneal hysteresis, which is a separate risk factor from a separate device measuring the cornea, but referring back to the ability of the optic nerve to withstand intraocular pressure and intraocular pressure elevation. And low hysteresis has been identified in a number of papers to be a separate risk factor from anything else, and a very strong risk factor for glaucoma. Most people don't have it. It's unlikely to occupy a significant practice device, practice device utilized in clinical practice. Numbers of under 9.5 for hysteresis are the more significant increased risk for glaucoma. In any case, here are the disc photographs for this patient. Again, you can see a large disc, a very deep disc. In fact, the bottom of the cup is out of focus. The vessels are displaced nasally, as often is the case here, although there's some anomalous vessels over here. You're looking at the neuroretinal rim. It's very thin. And you're highly suspicious of this patient, of course, but you go back to the IOP, and even though the corneal thickness is very thin, you don't know what the true IOP is. It's probably higher, but how much higher, you don't really know. And I would just encourage you to proceed on in trying to identify whether or not there's true glaucomatous damage in this patient. Treating this patient at very low pressures is going to be difficult. So as we said in the last case, wait to see if something is definitively there, wait to see if something is changing, unless you have some other overwhelming reason to treat this patient. Here are the first set of visual fields. Again, just sort of the messy stuff that we see in patients. As Joe said earlier, you better be a very good visual field test taker. Otherwise, you're just going to have to do these things every so often. And that's what we ended up doing with this patient. A series of visual fields over a couple-year time period, with things just moving around and never really in exactly the right position. But maybe more suggestive down here in 2015. And then we want to start to relate it to the OCT findings. And so here, and as you drill down here, and as you know from your OCT device, you can get a very accurate measure of the disc size or the disc area. And for this patient, it's 2.75 millimeters square, which is quite large. And I'll talk more about that in a second. And so the question really is this thinning that we see here on the retinal nerve fiber layer on the thickness map and the deviation map due to the large disc size and the axons being spread out over a larger area, or is it true glaucomatous damage? And here's the ganglion cell analysis. This is sort of like the circular cookie cutter pattern that you see as a lot of artifact. And probably I would argue in this case here is most likely to be this red disease thing where it's red, but it's not true disease. Now, to take a deeper dive into this, at least with the Cirrus OCT device, you need to dive into the reference database, and you need to look at the types of patients that were included in the reference database. So as you know, all OCTs, in order to give you the color coding, red, yellow, green, need to collect normative data or a reference database, same thing, reference database, normative database. And what we identify is that there are very few patients in the study with a disc size of over 1.8 and virtually none with anything near to 2.75. So basically that's just going to throw off the rest of the analysis and everything. So you have to be very careful as you scan patients. You want your OCT device to come to rescue in these really hard cases. You know, here's optic nerves that look really suspicious. How can they not be glaucoma? And then you get red disease on the OCT, and you don't know what to do. Many of us just end up treating the patient because it seems like the right thing to do. I'm just suggesting that we need to go back and look at all the risk factors here. And in this patient, we had a high IOP of 20, the very thin corneas. The hysteresis was one of the tipping points for me here. I'm not really sure how much the OCT weighed in my decision. I should probably also include in there we had variable and inconsistent visual field loss. To our point also earlier, there's been minimal progression over time. I'm not sure how much that's from my treatment. And I can't actually recall, I think like the other cases, we started treatment at a pressure of 20. We probably only got the pressure down to, 16 or 17. And we felt that like that was enough, but we didn't need to get out the sledgehammer and start really over treating this patient at this point in time.
Mike, if you can go back to the OCT real quick.
Oops, there you go.
I look at this, I can tell you what the tipping point to me is actually on the thickness map in the right eye, superior temporal, and a little bit on the inferior temporal. Those blue areas look like wedge defects. No, not on the thickness, go on up top to the thickness map.
Up here. Yeah.
No, superior temporal, inferior temporal. It looks like there are slit, right there.
Yeah.
A study came out a couple years ago on Cirrus, and they compared all the parameters of Cirrus to red-free photography, and they found that the parameter that was most associated with the gold standard of red-free photography was the thickness map.
Yeah.
So I actually look at it.
The thickness map is very good. Joe, I still question it in a disc of this size.
Mm-hmm.
But it is really, it is important. And there's a whole lot of many other pieces of information on that. But I do just point out that we have to be careful, particularly, I don't have well, maybe it's coming up, myopic examples of these patients where, high myopia confounds your readings on the OCT. Not the case in this patient, but in other patients where you have to be careful in the interpretation of your data. So let's take a look at this 43-year-old patient who was referred in to me for possible open-angle glaucoma. I'll share with you the referral sheet from the external doctor's office. They did eye pressure readings with NCT of 17 and 17. They actually used the FDT screening device and found 2 points in the superior nasal field in the right eye. At the doctor's office, they actually took photographs, and despite modern communications in the past 5 years, the patient took a photograph of his disc photos on the doctor's monitor in the referring doctor's office. And that's what he shared with me on his phone. So I took it off his cell phone. I included it because I thought it was so cool that, whatever camera system you're using, you can clearly see the nerve fiber bundle defect there in the back of the right eye. And here's pressures are at 17, but you've got the field defect. This is how glaucoma presents to us. I measured the pressures at 21 and 21. Basically, all the background stuff here was normal. The perimetry was very thin. This is the corneal hysteresis findings that I've mentioned a couple of times, and this is the waveform score that you get from the instrument. Both of these values are very low, indicating a high risk of having or developing glaucoma in this patient. It's just another data point. You don't have to have it. It's not part of the standard of care at this point in time. Here is the, in fact, I think I've shown you this photo earlier in our optic disc section, the nerve fiber bundle dropout there that is, again, very prominent, admittedly, and I'm, sort of cherry picking significant cases here. Here's what the field looks like. I point this out to show you how it's arcuate and central and doesn't have to be peripheral. And the left eye is, essentially normal. And you can, well, I can't show you the left eye here, but there was not any nerve fiber layer dropout on the left eye. And if you look at the OCT, this is the type of pattern that you see on the retinal nerve fiber layer. And to Joe, to your point earlier, there on the thickness map is that blue wedge defect that you see inferiorly. It looks a little bit larger and different on the thickness map, but I agree with you. The thickness map is a great, I said this should be deviation map. On the thickness map, it's right there. And you can look at the left eye. Maybe there's some early loss out here. You can look at the asymmetry and the overall average thickness. You can look at the quadrant and clock hour plots. You can see the depth of this cup, how deep it is. Those are all the features that I would really pay attention to. And if I could look at it more, I might look at this RNFL thickness curve, and you can see there's great asymmetry between the right and left eye there in the superior region, and I guess somewhat in the inferior region there, but hard to see it on that plot. And then here's the ganglion cell analysis here. And Joe, what do we call this? Our Nautilus sign, right?
It's the Nautilus shell. Well, the technical term is the Nautilus shell of Sauka.
I knew I had to give you credit somehow.
Thank you very much, sir.
But that's that cutout there of some people call it the squeegee windshield wiper effect, whatever. But more importantly, I think what I like to do is use this panel map report and see how these are correlated together. And as I was saying, I tend not to treat glaucoma just based on ganglion cell stuff. I want to see it related to the retinal nerve fiber layer here. Of course, this is a relatively easy to diagnose patient based on the photograph, the nerve fiber layer dropout, the visual field. The only confounding thing is that the patient did not have very high eye pressure. Only in I think we were in the range of 20 or so. Yeah, 21 and 21, 22 and 22 with very thin corneas. And basically, decided to treat the patient after getting all the information. And we, once again, I used latanoprostene buno to treat the patient, was able to bring the pressures from 21 down to 14. So here I was able to hit a very reasonable target pressure of at least a 30, even over 35% drop. Well tolerated, no side effects, follow closely, what other things do we need to do? And then, unfortunately, the patient was lost to follow-up for a while, sent the letters, the phone calls. He came back a couple years later, and I don't have, I guess I do have his clinical data. You see what his eye pressure was when he came back, 31 now and 23. He actually noticed some change in his vision when he took his eyeglasses off for cleaning. He noticed that his right eye was blurry. He had an APD in that right eye, different camera system and different photograph, and a little bit blurry, unfortunately, but a significant increase in the neuroretinal rim and notching change inferiorly in the right eye. Let me show you the OCT. Even more change, but sort of hard to see. I think the visual field will really tell you how rapidly this patient progressed by getting lost to follow-up because he thought he was doing well. It was partly a COVID-related incident. And again, that's what his field started off at, and 3 years later progressed to this. So obviously education, documentation, all those things are really important in these types of cases. Perhaps this is a good time to point out why visual fields are so essential. We have to use them for our staging and severity scaling of glaucoma. And our polling question here, Joe, maybe this will be the last one that we get in as we're getting here to the end, is asking, what is the definition of mild glaucoma by the American Glaucoma Society and its ICD-10 staging system?
Well, as these are rolling in, we have a number of questions here.
I bet.
Let's see. Does a patient with a Drans hemorrhage require immediate treatment on the first visit if they have an IOP of 20 and an average corneal thickness and a pericentral scotoma?
Absolutely not. I would never treat a patient on a single visit, even post-Drans hemorrhage. First, ascertain and confirm that the Drans hemorrhage is not due to some other non-glaucomatous entity of a hypertensive diabetic PVD origin. If it does seem to be related to glaucoma and the pressure is 20, go back and collect all your information over the next 1 to 2 months. And that certainly is a high-risk patient with a disc hemorrhage, likely going to need treatment, but do not start right away. Get at least 3 pressure readings at different times of the day, and then decide to start treatment and shoot for a 30% drop in their eye pressure.
What's your hysteresis threshold for increased risk of disease? Is it under 10?
I usually go under 9.5. The other problem I didn't reference with the hysteresis is that the value can be variable. And that's one of the drawbacks of it, is you have to look at your waveform score. That's why I showed a picture of the waveform scores. It can, just like we were talking about with tonometers, Joe, hysteresis values can really fluctuate widely depending on the quality of the measurement. So I usually go under 9.5. Again, I never go by just one piece of information. It's a constellation of risk factors.
Is ganglion cell analysis software considered standard of care at this point, Mike?
I don't have I want to say yes is a short answer. I don't know if it's a true standard of care in a medical legal sense.
But it is important, of course.
It is very important. Joe, these are great questions. What a great audience you have.
Oh yeah. No,
they are right on. This is a Sunday morning. You guys are awesome.
And for some people on the West Coast, even more morning than others. Can you speak to the association between obstructive sleep apnea and normal tension glaucoma? If a patient is started and compliant with CPAP or NTG diagnosis, does it factor into your clinical thinking?
There's 2 schools of thought here. One is that there's an association and it's relatively strong, and the other is from a number of research studies and clinical studies on hundreds of thousands of patients, is that there's not a very strong direct correlation. I tend to fall more in that camp. I think it's imperative for us to identify sleep apnea and refer our patients for it. I treat it separately. If they have normal tension glaucoma, I'm just going to focus on that. I don't really know what's going on with this CPAP thing. It may be a risk factor. It may not. I got to focus on their glaucoma disease. And that's sort of where I'm at with it.
There are so many studies that contradict,
Yep.
On each side. When people ask me this, is it a risk factor? My response is, do you want it to be? If you want it to be, it can be.
Right.
If you don't,
right.
It doesn't have to be.
Yep. I find I don't want to get lost in the, I don't want to lose track of what I do, which is treating the normal tension glaucoma. I strongly recommend get your sleep apnea taken care of, wear your CPAP device, all these other things. But I got to focus on the thing that I know.
Yeah.
And I don't think we have enough clinical information of such strength that it tells me what to do with the sleep apnea.
You've used a lot of examples, Mike, of latanoprost, Bunod, Vyzulta. Is cost an issue for you?
Yes, it certainly can be. It's a branded product. Those were actually the medications I started in those cases. It is often my first line go-to medication, but there's often, I should say that, yes, it is a frequent use of mine. More so, I have to admit, I use latanoprost as my first medication. And then I find that it's a lower barrier for prior approval to get to Vyzulta. But the formulary coverage has improved over the past couple of years.
How do you factor in keratoconic patients with central corneal thickness 300 microns and transplant corneas with thickness of 600? I think we probably covered that, but
Yep.
you can just briefly wrap that one up.
So keratoconics are tough. They have very thin corneas, very low IOPs typically. I go based on the best observation I can get of the optic disc, a visual field, and an OCT. Quite often, all of those have confounding, artifacts. And it's sort of like the other case where it comes down to sort of a little bit of a gut instinct and assessment of all the risk factors. And if I feel like the patient is better off with a treatment that is safe and well tolerated, then that's what I go with. But those are really tough cases, no doubt. And there's no clear clinical practice guidelines for that.
How long ago did the majority of eye care physicians stop using correcting factors to IOP based upon central corneal thickness?
Say that again?
How long ago did the majority of people stop doing IOP corrections based upon CCT?
Oh boy, Joe, you gotta, I'm gonna say 15 years.
Yeah. And here's a question I'm going to enjoy. I like this question. Is it necessary to upgrade to OCT if you've been using a GDX to monitor patients for the last 10 plus years?
I believe so. Yes. I'll keep it short. I mean, the GDX, I think you and I like the instrument a lot, Joe.
Yeah,
but
loved
it's
it.
still sort of all over the place with the corneal polarization effect. OCT clearly outperforms it. And again, I'm not selling anything here, but I showed some examples from the Maestro. And if people haven't seen the Maestro 2 from Topcon, it's like 40K. It's a camera and an OCT device. And you have to have the practice to support it. You have to have the medical necessity and the medical building part. But I think that you could say OCTs overall are sort of the standard of care at this point in time. I would not want to have a suspicion of glaucoma disease and not have an OCT.
I mean, I like, I like the GDX. It was a good device in this time, but it's kind of like, it doesn't work. Yeah. But it's kind of like watching a tube TV versus, we got HD out there now. All right. I'm going to end our poll.
Yep.
And a small nasal step or arcuate visual field defect is the predominant choice.
So that is not correct. So I'll just wrap up. We've got about 3 or 4 minutes left here, Joe.
You get about 5 minutes.
5 minutes, yep. So about 10 years ago, the American Glaucoma Society redefined a staging or severity system to be implemented with the ICD-10 coding system. And the definition of mild stage glaucoma is no visual field abnormalities on any visual field test. So only moderate and severe stage glaucoma have field defects. So I'll show you on this slide here. This is sort of the textbook. This is the example the AGS provides. It reiterates that we are primarily diagnosing glaucoma, from risk factors, from OCTs, from other clinical findings, and we are not relying on a visual field. If we have a visual field loss, visual field defect, if we have visual field loss, we automatically put that into a moderate stage. And the terms we use are mild, moderate, severe. And then there's two examples of severe, either those with defects within 5 degrees of fixation. So you can see right here, it gets into that central point right near to fixation, or you've got field loss in both superior and inferior hemifields. So that is a very large change from what we used to teach a long time ago, Joe. But these are the new guidelines. And here's again an example of mild stage glaucoma. We used to use this term, and maybe we still do, pre-perimetric. But that's where we're at. So perimetry, though, is still an essential part of glaucoma care. There are new programs and new testing algorithms. There's things called see to faster and other things. You don't need all of that. We talked a little about this morning about using 10-2 visual fields. And this is the reason why, because I've shown you any number of examples where there's this inferior retinal nerve fiber layer loss, and that tends to affect the central visual field. So here's a 10-2 grid on the left and a 24-2 grid test pattern on the right. We are undersampling the central 10 degrees. There's only really 12 test points in the central 10 degrees. We're missing large scotoma within the central visual field. And here's an example of that. Same patient tested on a 24-2 versus what was found on a 10-2. So it makes it tougher. There's no doubt, testing your patient more frequently with more visual fields can be more difficult. Here's a much less dramatic example of a patient with some central field loss, just a little bit on the 10-2 down here from the other thing. So in summary, I would say that, the 10-2s are reserved for the good test takers, generally younger patients. They should have minimal to no defects on 24-2. If you have significant 24-2 defects, you probably don't need a 10-2. I indicated earlier that if you have a very abnormal macular or ganglion cell scan on your OCT, that's a good indication that you should do a 10-2. High-risk patients should get a 10-2. And again, if you can get it, it's great. It's not a have to do, but it's identifying who needs it. And if you have a Humphrey field analyzer, again, not pushing or selling Humphrey field analyzers, they have come out with this new test pattern that is a 24-2C that incorporates an extra 10C for central points to try and help us avoid doing the laborious 10-2 visual field test. And so a number of papers have been published about this. And while it's still only a couple years old, it's a very fast test, less than 2 minutes. And really has been, it's not the only test I do in my practice. I'm still using a lot of see to fast strategy, but it is a very helpful addition with a software upgrade to my Humphrey field analyzer. Joe, maybe this is a good breaking point.
I think it is. We had a couple of real quick questions and then we'll just wrap it up. Please comment on SLT as initial or adjunct treatment in your practice.
SLT, a lot of good things, a lot of, it's not the answer in many patients. If you have very, early stage like glaucoma, I think SLT is a great either first line treatment option, although I still say the majority of patients end up trying medication first. And then after they find out that they don't like medication, SLT is a great substitute for their topical medication. It can also be an adjunct, as the question offers. And yet it doesn't last forever. And you have to be thinking as a glaucoma practitioner, what's going to happen 5 years from now? Because these patients only get older. They're generally going to stay with you, and you want to have, all the options open for later on. Maybe that's a cataract surgery with a MIGS device. I don't know, but SLT, it's okay.
And here's a question. Let's see. Low reliability test in the visual field showing a defect. Repeat it. Same low reliability, but same defect. What do you do?
two unreliable visual fields.
But same defect on two unreliable visual fields.
So my first question is, does that defect correlate with something else? If that defect is in the right location, the right shape, it's not edge points, and you have an OCT that goes along with it, meaning the structure function correlation, then go with it. But if it's just two random things or two consistent things but don't make sense with the rest of the case, I'm not going to treat just based off that.
Yeah, my magic number is 3. I'm not talking about unreliability, but if you have a defect in the same general area, I mean quadrant, 3 times in a row, I mean, how often is that going to happen by accident? That's important to me.
Right.
Well, thank
And
you.
also pointing out is like it still could be something else and not glaucoma.
Yes, absolutely.
Look in the back of the eye, look at the optic nerve.
Mike, are you seeing my screen now?
I am. I switched off.
All right, very good. Well, thanks, Mike, for that really engaging talk. And Mike, we have been doing this. I can't tell you how many webinars and hours of education we have done since the beginning of this pandemic. But I got to say, I was probably most engaged with your talk overall. We're certainly one of the most, and you certainly are adhering to one of the prime rules in show business, and that is leave them wanting more. And you've left me wanting more. So even if we have to add an extra day or an extra session, we're going to try to get you back, because I think you did such a terrific job. So thank you so much, Mike.